First, I'd like to thank the conference organizers for inviting me and for Dr. Parsons conscripting me into the gene therapy team. It's been a fun ride, and I've learned a ton from just coming to meetings like this and speaking with all of the experts in this field. So really my main objective, considering the time constraints, is going to be to provide a framework for you guys to understand what the immune response is to the gene therapies that are being administered in the clinic now. So I'm really going to be focusing on the DMD and SMA therapies that are approved by the FDA. Just first, so just a little primer on AAV, because that's what we're responding to. It's a very tiny virus in the parvovirus family. It's a dependovirus, which means that it requires a co-infection with another virus to produce proteins that make up the machinery that it can use to reproduce itself. It has a very simple genome. It's a single-stranded DNA, linear DNA. And you could see there's basically just a couple types of protein. The VP proteins are the capsid proteins. The rep proteins are stuff that helps prevent the cells from turning it off and maintaining latency. The main issue, which Russ had spoken about, was how to get the biggest gene in the genome into the smallest virus that we know about. And what happened is they just took out all of the middle of the protein, and it still seemed to be effective, and that's what these mini and micro dystrophins are. All right, so you have 37 trillion cells in your body, and like Russ had said, we administer about 1,000 trillion viruses. So that means that there's more than one virus for every cell in your body, which you need to do because we're starting in a vein, and we needed to get into the CNS. So that's a lot of virus that you need to administer. So with the virus, there are a number of immunoreactive components. There are the capsid proteins, which are the first things that your immune system is going to see. It's a single-stranded DNA that comes from a virus, and you have innate mechanisms to respond to that. And then there's a transgene, and then I'm not even sure what I meant by regulatory protein, so we're going to skip over that. Okay. So, all right, this is where I'll start with the framework of how you need to understand the immune response. Okay, I've split it up into a few different waves that reflect the timing of the immune response and also different aspects of how your immune system responds to viruses. So the first thing that happens is an innate response. Innate meaning that you have receptors in your immune cells and even in cells that aren't technically part of the immune system that are hardwired to detect foreign antigen epitopes or foreign structures. And so the first thing that happens is you put the virus into the blood, and there are cells in the blood, and then there are cells that make up the blood vessels, and then the blood takes the virus to the liver and then other places as well. So throughout your body, you have an innate immune response. And so some of the things that could include, I mean, even beyond that, if you had preformed antibodies or even cross-reactive antibodies. Now, the patients are screened for these, and if they have preformed antibodies to the AAV capsid, then they don't get the gene therapy. But you could even have cross-reactivity with antibodies that exist because of some other exposure. Those can induce complement activation, or complement activation can occur independent of the antibodies. At the cell surface, you have toll-like receptors. Your cells can, the virus can be internalized into endosomes and interact with toll-like receptors, which can initiate an immune response. You have potentially surface antibody on B cells that can respond, and then you can have complement activation on the cells. And then intracellularly, right, the capsid does go into the cell, and then it gets uncoated, and then the DNA enters into the nucleus, there are sensors that can respond to both the capsid internally and then the DNA. And so there are multiple layers of an immediate immune response, and you see an immune response instantaneously within hours of administering the virus. So following that, and this is more of a delayed immune response than the initial innate immune response, is this second wave, and that's the initial adaptive immune response. What happens is that the viral particles will be brought to an immune organ like a lymph node or the spleen, and then will be presented to B and T cells, and then B and T cells can start responding to specific parts of the virus that they specifically can recognize. What occurs at that point is you start producing IgM, and that's when you'll start seeing IgM specific to the virus. And then you can also generate some effector T cells as well, and a little bit of IgG as well. Once this activation occurs, though, there's another process that starts to be formed, which is the third wave, we call. And this, we're still doing the second wave. Okay, so I forgot how I categorize these. So beyond that, you start forming germinal centers where you start to make high affinity antibodies against the virus, and then produce more and more memory B cells, and then cells that can become long-lived plasma cells, and enter into the bone marrow and produce IgG against the viral capsid in perpetuity. The third wave is some of these memory cells, right? Now you have not only the capsid that you're responding to, but you have this protein that possibly wasn't produced in the past, and you have no central tolerance to, where now you have CD8 T cells that might recognize that and might see that it's being expressed all throughout the body. And that's where you can get a memory cytotoxic response that can kill cells that are producing the virus. I mean, not the virus, the transgene, sorry. All right, so this is sort of the timing of how these would happen, right? The initial response it's immediate, this innate response, and then it lasts possibly to 2 weeks. But in that first week, towards the end, you're also getting that initial adaptive immune response. And then you have, and that's your second wave. And then there's this third wave that's probably around the second week, where you have this prolonged, first you start reacting to the transgene itself, and then you have this prolonged production of antibodies against the capsid. And potentially, you could have reactivity against the transgene itself, but if you develop tolerance, then that should wane over time. And so there are various obstacles that the immune system introduces into this problem of delivering gene therapy to these patients. And there are strategies that try to circumvent all these. So the first is that I'm focusing on here is the adverse events that can occur that are mainly driven by the immune system itself. But also the long-term response prevents you from being able to redose the gene therapy, or can cause decreased efficacy if you're killing the cells that are producing your transgene, and then they won't persist. So these are some of the immune mediated responses to gene therapy, and I'm not going to talk about them all, and Russ and Julie have recovered a lot of this, and so hopefully we can get to the question and response section pretty quickly. But there are some others. The only one that wasn't mentioned were there have been cases of hemophagocytic lymphohistiocytosis, which is basically a cytokine storm issue. But TMA, it's the triad of thrombocytopenia, hemolytic anemia, and uremia. And so there have been reports throughout the development of these drugs of patients that have had TMA. There was the timing was established to occur in about the first week, and it was associated with a decrease in complement proteins, which indicates consumption of the complement proteins, which indicates that there is some sort of activation of that cascade that has led to their degradation. How the incidence of this phenomenon is not completely clear, but it does appear to be a rare event, but something that you do need to watch out for. In the onasemnogene studies, there weren't events reported. However, post-marketing, I think there have been about 32 cases, and that might be an underestimate, reported. When it was reviewed, it was felt that maybe 15 of them were real, and that's out of 3,400 patients treated. And so it's less than 1%, but it could be around 0.5%, right? Which would put you at 1 in 200 patients. And there was one patient that died, but most of the others, it's treatable with a complement inhibition with eculizumab. So initial DMD trials reported TMA as well, and it was actually at a much higher incidence than in SMA. And so, I mean, I'm not sure how accurate this is, but gives you a perspective on how frequently you might see TMA compared to other things. So in general, it's very rare, and it's orders of magnitude more common following gene therapy, but it's still a rare outcome. Hepatotoxicity can occur as well, and this occurs at around 1 month. So this is probably a CD8 T-cell mediated response, and it's not part of the innate immune response. And so you see very large increases in the AST or ALT in quite a significant number of patients that have received DMD gene therapy. This was actually an SMA report, and so it was up to 5%. This makes sense because if you look at the biodistribution of onasemnogene, all the way on the right there, that's the liver, right? So a massive amount ends up in the liver, orders of magnitude greater than other tissues. So that's where you have a lot of the transgene being expressed, and the immune system will target that. And then other rare events include there's a report of HLH, and then I guess now it's 3 full-term infants with necrotizing enterocolitis, and possibly there will be more. And so I just wanted to show this figure that came from the Barry Burns group in Florida that they just published, which gives an idea of what the timeline of the different adverse events are and the immune response. And I think just reviewing this shows how it sort of confirms what we think of as far as the framework for how the immune responds. So there's, I don't know if you can see that. Oh, good. Okay. So there's the initial dosing occurs here, and then you start to see the complement and platelets come down, right? There's an innate immune response that's occurring in this first 2 days. Now, their group believes that there's actually, that the platelets come down because IgM is starting to be produced in lymphoid organs, and that's what they said 5 about here. So, and then with the IgM is what's causing the complement activation, and that's what's causing the drop in platelets. And then by 3, you can start to see an early increase in AST and ALT. So that occurs in the first week. But what happened? And that's more of an innate response. The liver injury and the liver failure that was reported occurred much later out here. And then the peak of complement activation is typically here at day 6. And so this is the current, like what their current model is. It sort of fits with what I just described, and I think that thinking about the immune response in multiple phases, including innate phase, early adaptive, late adaptive, and then this prolonged cytotoxic potential is a helpful way of thinking about it. And so in summary, I just say that these are rare adverse events that you're going to see. They're all brought about by the immune system. And then how to deal with them, I think the specific therapies that you want to choose should be based on an understanding of the multiple waves of the immune response. And so, I think we'll see more gene therapies that are to be approved in this space, and this is a problem that is going to stay, and I think could be more prevalent and something that we're going to have to focus on in the future.
All right. Well, thank you, John, for the invitation, and everyone. I was here last year, and it's really lovely here. It makes you want to come here. We walked through the park, and it smells like eucalyptus. And I'm not an immunologist, John, but I play one on TV. And it's interesting. I do have immunology background. I did my PhD in immunology in like the late 1990s. And it's kind of stuff comes back, that stuff I hadn't thought about in 2 decades now becomes really important as we think about gene therapy things. So I it's just my disclosures here. Just to start with this, the universe is expanding, and so it's my task to talk about DMD therapies, and we have 30 minutes. Which is not very long. So this is just an interesting image comparing the Hubble Space Telescope and the Webb Telescope. And it seems like we live in this world where our universe is, and our mind is just blown every time we go to a meeting, and there's more to talk about. And we're really not going to be able to get web level detail today. We'll hopefully talk about a few things that are interesting. And so I'll just start off talking about some of the approved therapies or the nearly approved therapies for Duchenne, talk about the details of the FDA approved, I shouldn't have done these things late at night, gene therapy, that probably spend some significant time on that, and then just talk about safety in gene therapy for a little bit. So since I'm first, I put in one slide about DMD. Hopefully everybody here knows DMD because we're not going to spend more than this very introductory slide, right? We're an X-linked disorder, about 1 in 5,000 male births caused by mutation in the DMD gene. It's the largest gene in the genome. It's freakishly large, like 2.5 megabase long of genomic DNA for that gene. But the overall disease is progressive muscle atrophy and weakness that really clinically manifests around age 4 with gait problems, progresses over time to wheelchair use in the early teens, and then cardiomyopathy and respiratory problems become big problems. And people now surviving into mid-20s and early 30s, even longer sometimes. So that's the very basic DMD. And then we're just going to spend the rest of the time talking about disease treatment. And you can think about those probably in different ways. Disease modification therapies, and corticosteroid has really been the mainstay of that for many years now, and we think a lot about that. But we have prednisone, and we have deflazacort that's approved by the FDA, and now we have vamorolone that's recently approved by the FDA as sort of corticosteroid. Givinostat is an HDAC inhibitor that's pending review at the FDA. And we have a number of sort of so-called failed therapies, these are just trials we've been a part of at Utah, but it's a Dalafil trial, we had a myostatin trial, we had a utrophin upregulation trial. There's lots of different ways to try to modulate progression of this disease, and some have been more successful than others. Even these sort of so-called failed therapies may have a role as we can start treating the underlying genetic problem and then perhaps go back to some of those things, which weren't all bad ideas. And then we have these sort of gene modification therapies. This would be things like nonsense read-through or exon skipping, where not gene therapy in the classical sense that we're replacing a gene, but therapy in this gene therapy in the sense that we're modulating either the expression of a gene or other aspects of its genetics. Then we have now just gene replacement, right? If you don't have the DMD gene, we'll just put one back in there. It's a simple problem, right? So I did want to just review some of the basics. So oral corticosteroid has been the mainstay of treatment for a couple of decades. And now at this point have multiple choices of what sort of steroid that we could think about. Deflazacort is approved by the FDA for the indication of Duchenne muscular dystrophy in 2017. Vamorolone's approved by the FDA just a few weeks ago. And overall, I think there's some things that are the same about them and some things that are different individually. They benefit strength and motor function. They prolong ambulation, which is where most of the study work was done early on, especially in prednisone. And there's no good data around starting or stopping rules, right? At what age do you start a corticosteroid that could have long-term side effects? Do you start in a child